Yeah, man, sir. Good evening.
Good evening, everybody. TJ, good evening, everybody now.
Anyway.
We're going to start at exactly 8, please. So let the host understand that once it's 8 o'clock, we start, please.
Good evening, Chemo.
Hey, my DBC, good evening. How are we?
We're good.
And thank you for accepting to host this event.
Powerful DVC. Good evening.
Danny G, how are you? All right, ladies and gentlemen, it's 8 p.m. on the dot. A big round of applause for the National Postgraduate Medical College of Nigeria. Professor Oyujo Mara, you have the floor.
No, call the chairman to open the meeting, not me.
Okay, chairman, over to you.
All right, good evening, everyone. Good evening, colleagues and junior colleagues. Let me welcome you to this one of the first series of TOTs. This is a very important TOT, which will be hosted and chaired by the Professor Rosemary Ogu, our DVC and a faculty board member. This is going to be on pre-patron book of case records and commentaries. We found a lot of issues, and as usual, we organize a seminar to educate us. So I want to assume that a lot of people here are residents who should definitely benefit from this. And of course, trainers also can also benefit from it. So I don't want to waste so much time. It's also a long meeting. I will hand over back to the MC, Professor Rosemary Ogu. Please, for candidates or for residents who have questions, note your questions down. When it is time for Q&A, you will be asked to raise your hand or put your question in the chat box, depending on whatever the host says wants. So thank you very much, and I wish all of us a wonderful and useful deliberation. Over to you, Madam DVC.
Thank you very much, Chairman of the Faculty, National Postgraduate Medical College of Nigeria. Mr. Faculty Secretary, Professor Oyujo Omero, I believe you're supposed to introduce the moderator.
Thank you, Mr. Chairman. Thank you, everybody, for joining us this evening. And also thank you, the residents and trainers with us this evening. Like the chairman said, this is a very, very important aspect of the training. Casebooks are so important to us because it is a foundational tool for learning, for standard management of cases. Unfortunately, we've seen this particular aspect being, will I say, not taken seriously by the candidates, and when they come to the exam, they find it difficult. It's really surprising that somebody should be failing on a case that the person managed. And this is why we want to redo this TOT. We've done it before for trainers, and now we also know we have very new residents who want to start writing casebooks so that they start on a sure footing. So we've assembled an area of very seasoned examiners and trainers. And to lead us this evening to anchor the whole show is no other person than the immediate past president of M1, a deputy vice chancellor, University of Port Harcourt Academics, and a very senior faculty member, Professor Rosemary Ogu. You are welcome to the podium, Mr. Chairman. Over to you.
All right, thank you very much, Faculty Secretary. Good evening once again to our distinguished senior colleagues and colleagues here this evening for the seminar on the pre-part 1 book of case records and commentaries. This is a seminar for all pre-part 1 residents and all trainers holding 7th December 2025. We have 5 presentations and then question and answers, and everything is supposed to take a total of 1 hour, 40 minutes. We've done 3 minutes already. We should be out of here by 9:45. And to kickstart the presentation for today, we will have the first presentation overview of the casebook for the National Postgraduate Medical College of Nigeria, choice of cases by modules and timelines. And it will be presented by the one and only Professor Mohammed Buka, a fellow of the National Postgraduate Medical College of Nigeria, the immediate past provost of the College of Medical Sciences, University of Maiduguri, a school where he graduated MBBS. Professor Booker is celebrated as the maiden professor for his pioneering contributions. He is also the third member of Senate of the Faculty of Obstetrics and Gynecology at the National Postgraduate Medical College of Nigeria. As of today, Professor Booker has about 119 peer-reviewed journal publications, and he was featured in the 2023 AD Scientific Index World Scientific Rankings, placing him 458th in Nigeria. His 189 YouTube videos have attracted almost 100,000 views. He has over 1,000 subscribers and more than 1,000 likes. Professor Booker has a TikTok platform with almost 1,000 followers as well. He's one of only 2 international ovarian tumor analysis certified experts in Nigeria. He served 2 terms. He served 2 terms on the TED Fund National Research Fund Screening and Monitoring Committee and is a national contact point for Horizon Europe. He's authored 5 solo books, 3 TED Fund supported and co-edited 5 others. He is the 79th inaugural lecturer of the University of Maiduguri. Ladies and gentlemen, please make welcome Professor Booker to give us an overview of the casebook for the college, choice of cases by modules and timelines. Professor Booker, please, you have 10 minutes. Thank you.
Thank you very much, moderator, for the kind introduction. Is my slide visible?
Yes, please.
So thank you very much. So I bring you warm greetings from Borno State, the home of peace, to my teachers, senior colleagues, trainees, and the moderator. The title of my talk is Overview of the Casebook for NPMCN, Choice of Cases by Modules and Timelines. At the end of this 10 to 15 minutes, we expect the trainees to state the required number of cases to be submitted, to define the timelines for writing the short cases and the long commentary, and to apply correctly the case selection in accordance with the designated modules by the faculty. Many of us, the trainees here, wrote 30 cases, 30 short cases, and 2 long commentaries. But today, our trainees are writing only 15 short cases and a long commentary. 7 in obstetrics, 7 in gynae, and 1 long commentary. If the long commentary is in obstetrics, then the gynae cases becomes 8, and vice versa. So what are the timelines for writing the short cases and the long commentary? We expect that as soon as practicable, the resident should start writing his or her short cases, preferably within 3 months of joining the program. But for the long commentary, we need the residents to imbibe the ethics of the specialty, learn the ropes, and that probably will take about a year before the resident drops the stick and become conversant with the routine, and then go ahead to write his or her long commentary 1 year after joining the resident training program. So let's go to the case selection by modules. This slide is the most important slide as far as my presentation is concerned, and I will read the slide verbatim. In writing up the case summaries, the candidate shows that he or she understands how to communicate effectively with patients, take appropriate and accurate history, examine the patient, request for relevant investigations. Not only that, the candidate should be able to analyze the history, examination, and investigations to arrive at a diagnosis to which he or she prefers treatment options, counsel the patient appropriately, treats and follows up the patient till return of good health or death. In the case commentary, the candidate appraises his or her care of the patient and compares his or her practice with current acceptable standards of care. There are 4 modules in obstetrics, 6 modules in gynecology, making a total of 10 modules. Candidates must choose all the cases from these 10 modules. In obstetrics, at least 2 cases, each from modules 1, 2, and 3 are compulsory, and at least a case from module 4. In gynecology, at least a case from all the modules. It's compulsory. Now let's look at the modules in obstetrics. Module 1, maternal and fetal medicine, antenatal care. Module 2, management of labor and delivery. Module 3, postpartum care. Module 4, core surgical skills and procedures in obstetrics. Let's remember that in obstetrics, at least 2 cases from modules 1, 2, and 3 are compulsory, and at least a case from module 4. Module 1, these are the cases that can be selected from module 1, from malaria and pregnancy to anemia, hemoglobinopathies, hypertensive disorders, endocrine disorders, multiple pregnancy, HIV/AIDS, and antepartum hemorrhage from placenta previa to approaching placenta, mobilely adherent placenta, and so on and so forth. In module 2, the cases that should be selected are assisted vaginal bridge deliveries, obstructed labor, ruptured uterus, operative vaginal deliveries, and some congenital malformations. What you observe is that how will you see a case of congenital malformation written by candidates? Because candidates go for what they believe is straightforward. If you always write on straightforward cases, when you encounter this type of cases, what do you do? For instance, if you write on this case, you know that it's important to invite the orthopedic surgeons because of talipes. It's important to discuss with the geneticists. It's important to bring in the anesthesiologist because of airway issues, and so on and so forth. So if you don't write on this type of cases, if you encounter a case in real life, what will you do? You don't have the knowledge and the skills to appropriately manage these cases. Module 3, postpartum care, postpartum hemorrhage, postpartum collapse, maternal removal of the placenta, puerperal sepsis, mental health issues, and breastfeeding challenges. Module 4 is about core surgical skills and procedures in obstetrics. Here you can see it's a case of cesarean section for placenta previa, episiotomy, vulvar hematoma. But the emphasis here is that if you are going to write on cesarean section, the minimum should be 2 and the maximum should be 3. And if you are writing on only 2, it shouldn't be the same case of elective cesarean section. If one is elective, the other should be emergency, or if one is emergency, the other should be elective, repeat cesarean section. So in gynecology, we have 6 modules. Module 1 is early pregnancy care. Module 2, common gynecological problems. Module 3, subfertility and gynecology endocrinology. Module 4, gynecology oncology, urogynecology. Module 5, sexual and reproductive health. And module 6, core surgical skills and procedures in gynecology. Remember, at least 1 from each of these is compulsory. Early pregnancy, incomplete miscarriage, inevitable miscarriage. And these are cases of ectopic pregnancy. Most times what we see is ampullary ectopic. Yes, that's the commonest, but yes, these are ampullary, but this is isthmic. I mean, this is femoral, this is isthmic, this is cervical, this is interstitial. So let us broaden our cases. Let it not all be on ampullary ectopic pregnancy. For instance, this was a case of cervical pregnancy managed with methotrexate. She became pregnant later and had a successful delivery. This interstitial was also managed with methotrexate, and she's now pregnant. So if you don't write on these cases, and all you write is just on ampullary ectopic, you miss out on these cases. You encounter these cases in real life. Common gynecological problems, yes, uterine fibroid. Yes, most candidates write uterine fibroid, but adenomyosis is a common condition. This is the case of adenomyomectomy. Why are we not writing on adenomyosis? Yes, benign ovarian tumors, like microcystic teratoma. Adolescent and pediatric gynecology. You can see rectal mucosa prolapse here, intersex labial agglutination. Module 3, assisted reproductive techniques, Asherman syndrome, imperforate hymen, cystic ovaries, endometriosis. Module 4, ecological oncology, from vulval, cervical, endometrial, ovarian, choriocarcinoma, molar pregnancy, and uterovaginal prolapse. This was a case of UV prolapse in a 57-year-old, but this was in a 41-year-old. So while this patient had vaginal hysterectomy before repair, this patient had Manchester repair. Module 5, sexual reproductive health, bilateral tubal ligation, another forms of contraception, insertion, removal, missing IUCD, pelvic inflammatory disease, and sexual assault, and so on and so forth. Module 6, core surgical skills like manual vacuum aspiration, myomectomy, total abdominal hysterectomy, with or without bilateral salpingolectomy, ovarian cystectomy, cervical cyclage. Now, I just want to emphasize one thing here. You see, this case, this is a case of Bartholin's abscess. All the rest are not Bartholin abscess. But the vulvar cases we see when we review case books are virtually on Bartholin's cyst or Bartholin's abscess. But this is a benign fibroepithelial lesion. This is a lipoma. This is a recurrent fibroid on the vulva. This is scanous cyst. This is epidermal cyst. This is vulval endometrioma. This is scanous abscess. So if all we write is on Bartholin's abscess, we'll miss out on all this. And that reminds me of what Abraham Maslow said, that when your only tool is a hammer, every problem looks like a nail. So let not all vulval lesions be Bartholin's abscess. Now, as trainers and trainees, we both have responsibilities. As trainees, we should ensure that all cases align with the recommended modules. But as trainers, we need to confirm that the cases submitted are selected in accordance with the modular requirements. It is expected that the long commentary should be started only 1 year after joining the resident training program. That is what we expect the residents to do. Or we expect the trainer to ensure that the long commentary starts only after the first year of joining the resident program. Today, copy and paste is as common as pure water. So our responsibility as trainer is not only to recognize this, but to also report to the appropriate authorities. I take a message: begin drafting your short cases as early as possible and commence your long commentary 1 year after starting the residency training program. And remember, only 15 short cases and 1 long commentary are required, drawn from the 10 modules. My final words: integrity is the foundation of scholarship. Those who attempt to take credit for someone else's research harm themselves most, because exposure and penalties are unavoidable. Thank you very much for listening. This is my further reading. I wait for questions and comments. Over to you, moderator.
Thank you so much, Professor Mohammed Booker. Please, a virtual round of applause for him. Thank you so much for that presentation. You kept to time, and that is awesome. Please, if you have your questions on the overview of the case book, choice of cases, by modules and timeline, please put them in the chat box or write it down and hold on to when we get to the question session. Thank you so much again, Professor Booker. Another round of applause for him. And so we move on to the next presentation, the anatomy and structure of the case book, short commentaries. It's going to be presented to us by the distinguished Professor of Obstetrics and Gynecology, Dr. Siri Dean, who is a professor in the Department of Obstetrics and Gynecology at the College of Medicine, University of Nigeria. He is also an honorary consultant obstetrician gynecologist at the University of Nigeria Teaching Hospital, Ituko Azala, Enugu. Professor is a seasoned trainer, supervisor, and examiner in the Faculty of Obstetrics and Gynecology of both the National Postgraduate Medical College of Nigeria and the West African College of Surgeons. Professor Dim will be speaking to us today on the anatomy and structure of the casebook short commentaries. Prof, you have 15 minutes. Welcome.
Yeah, thank you, Professor Rosemary. And thanks to the faculty hierarchy for the invitation. I thank the audience. My topic is shown, and my name and affiliations are shown. So every key information I'm going to give you today is from the faculty guideline. And I want to highlight that is 2024 guideline, the new one. The next 15 minutes, I will have introduced and discussed my topic using this outline, introduction, case anatomy, case structure, and I will try to conclude. By way of introduction, let me remind us that submission and approval of book of cases is a prerequisite for Part 1 exam of the National College. If you compare this to the West African College, you notice that for West Africa, the book cases or book of cases is for the fellowship exam, okay? So each case consists of case reports and short commentary. And every trainee is expected to understand the requirements and the structure of the casebook. So we expect some minimum proficiency from a trainee to be able to write the book of cases. For the case reports, we expect the trainee to understand how to communicate effectively with patients, take appropriate and accurate history, examine the patient, know the requisite investigations, and be able to analyze the history and so on. This I snipped from the guidelines, so you can look at it. So if you're just coming from the private practice, especially in those areas where history is not usually detailed and examination is not often, occasionally, thorough, and you give investigation as you like, and then polypharmacy may be the order of the day. You're encouraged to rapidly unlearn those attitudes and begin to, acquire these proficiencies. Now, for the long commentary, we are expected to be able to appraise the care of the patient and compare her practice with current acceptable standard. So, when you are preparing to write your casebook and when you've started, what do we expect? You should have read widely about the case and the topic. Professor Booker said it started about 3 months. Well, it's okay. So we expect you to have read relevant textbooks and practice guidelines and others concerning the topic of interest and the case. Then you assemble and review relevant literature, okay, full articles. Emphasis should be on local publications on the topic of interest. Then when you do your preliminary drafts, you're encouraged to submit to a senior resident, of your choice, one who you expect to be honest with you, okay, and be able to tell you the truth. So he or she will now go through the write-up first. You now make the revisions and submit back. It's after this step that you now get the thing, your draft, revised draft to your supervisor, who's a consultant, who is expected to read, make corrections before you now develop the final draft for each case, okay? So the job of your supervisor is to read the revised draft, not to just sign your case, whether he or she read it or not. Now, why are we discussing this? We're discussing it, I believe, because the guideline has changed, okay? And the change involves the number of cases and the spread. And then the faculty now talks about logbook process. That's the real-time submission of activities. You know, as you take cases, you're expected to submit them, real time. Professor Booker had talked about this, so I will quickly go through them. I have tabulated them for the ease of understanding. The one I marked bad is where we were before. And what the ones that I didn't mark, this ones is where is the current thing. The number of cases have been reduced. Well, in as much as it's easier for everybody, I think it makes, when we are doing the 15-15, you're able to finish it. The transformation is usually very automatic and very obvious, okay? So you're expected to do 7 cases obstetrics, 7 cases gynecology. Then you choose extra one to make it 15. So this can be from either obstetrics or gynecology. So that gives you 11 cases. Now your long commentary has to be only one. Either you're choosing obstetrics or gynecology, okay? So this is what we want you to do. And this is what you should do. Spread of cases. In the past, this kind of guideline is not there. It was your assessor will now decide whether the spread is wide enough or not. So this is a good guide for us. The spread should involve all aspects of O&G. Okay, Professor Booker had talked about the 4 modules in obstetrics and the 6 modules in gynecology. This is just to help you, spread their case. Now, this one is critical. It's half of the 15 cases. Well, 7 is not up to half. So at least 7 of the 15 cases must be derived from those you've submitted electronically. So there's a lot of follow-up to do on the part of the faculty admin, because you need to now look at what the candidate has submitted before and be sure that 7 out of 15 minimum are derived from them. Now, spread of the cases, Professor Booker had equally talked about this. I highlighted what I tabulated it and highlighted what we need to. So the first 3, you have 2-2, that's for obstetrics. And for module 1, you select 1 minimum. And you can see when you've done that, that's complete force, that's 7. But remember, you have an extra which can come from either obstetrics or gynecology. So if you decide that the 8th case or the 15th case will come from obstetrics, then you can now choose from any of the 4 modules. But when you come to gynae, you have 6 modules, and you must select at least 1 from each of them. That gives you 6. That means you have 1 extra, which can come from any of these modules. Okay, and if you decide that the 15th case will come from gynecology, that means you have 1 extra case which can come from any of the modules. I hope this will help make it clearer. Now, with respect to cesarean section, cesarean section can come from more than 1 obstetric module. Okay, but we expect at least 2 and not more than 3, right? And we don't want more than 1 emergency. We don't want more than 1 elective repeat, and we don't want more than 1 emergency repeat. So this guideline really helps us to ensure that the spread is good enough. Now, how do we select cases? I'm using this module 1 for obstetrics, to illustrate. Now, under this module 1, I've developed these 4 case titles: febrile illness in pregnancy, eclampsia in an unbooked stabilization and emergency CS, cardiac disease in pregnancy, spontaneous labor and forceps delivery, symptomatic UTI in pregnancy, antibiotics therapy, So these are the 4 cases or titles I've developed. So now let's see how we distribute it. I've tabulated this. What I'm trying to illustrate here is that a case may overlap into another model. You have the core model from where the case comes from, and the other model where you can overlap, where you can even assign it to. So if you look at this first one, which is on malaria, if you look at it, is essentially should be for module 1. There's no clear overlap. But if you look at this one, eclampsia, stabilization and emergency CS, it could be from module 1, but because you have emergency CS, you can put it in module 4. The same thing with cardiac disease and forceps delivery. The core is module 1, but you can put it in module 2. Then the UTI, well, this seems to be only for module 1. So if you so love these 4 cases and you've written them, you are not only restricted to module 1, where you can only present only 2. You can spread it to other overlapping modules so that you can accommodate all of them. Now we look at it like this. I've tried to develop a revised, so I'm suggesting a revised supervisor's attestation that now show the module number. What we have now do not show module number, and I hope and I wish that the faculty will accept this. Equally, the faculty admin staff can use it to screen submissions. Okay, let's not allow the assessors to be doing the screening. If the candidate does not adhere to the number of modules as expected, it's returned to him or her to do the needful before he can even go to the chairman and the secretary for assignment. So this is, the candidates can look at this and help them to adhere to the spread of the cases. Now let's go to the case report, the format and content. We know that I got this to give us an idea. Every case, you have a case number. You can see this is obviously case 4, followed by the title. Then the patient's initial, hospital number, summary biodata. All these things are in the guideline, and I've given you a template, how this is for obstetrics, how it looks like. I need to just tell you one thing. People copy a lot, and often they make reckless mistakes. You said you did an elective cesarean section on a Sunday. That is obvious copy and paste, okay? So if you are copying, which I don't encourage you to copy, why not be wise and very wise? Now, case presentation format, this I got from the guideline, and it's very elaborate, and I thank those that developed it. So the case presentation should follow the format, presenting complaints, just the way we take history, okay? Now, it says all managed labor cases, there must be a pathograph. Some people even submit their cases without that. And they said each case must be duly signed by the managing consultants. And that takes us to what this suggested model. Some people submit their book of cases without supervisor's attestation page. Such submission should not go beyond the faculty admin staff. That's my suggestion. Now, the case commentaries, we've done with the case report now, the case commentary. We expect the candidates to focus the commentary on the case of interest and should show evidence of in-depth literature search. Okay? Should be able to address decisions in the case managed and give reasons for such decision. I highlighted this because if you're able to do this, that means you've transformed to a specialist. And if you're able to do that for 15 cases, the transformation is often clear in the way you handle cases. You know? Now, we expect what count to be 650 to 1,000. I think 1,000 is too much. And if you use the Time Roman size 12 double space normal A4 margin, which is often recommended by faculty, a page is about 250 to 300 words. So we expect about 2.5 pages to 4 pages. I don't think you should get to 4 pages. Okay, it has to be concise as possible and and rich in content. Now, some of us may not be very familiar with how to do your word count, so I try to show what we do. So if you highlight the area of interest, maybe a whole page or part of the page, you click on the review. This is review on the toolbar. When you've clicked that, you go to the word count and click it. This dialog box will open. It shows you the word count, which is 54 here. And there are other things you look at, you can get from this. So as a junior resident, I had to buy my first laptop. I learned how to use word process. I learned how to do PowerPoint. I installed a typing software and learned how to type. I bought a printer, laser and DexJet. So since then, I type all my projects. I typed everything and typesetted it. The only thing I did was to go outside and print. Okay? So some of these things you can do yourself. That we improve your capacity and your typing speed. Now, the structure of the commentary. Commentaries are like an essay. You have to arrange it systematically and in paragraphs. When one is reading it, you will know when you are the introduction, the body, and the conclusion. You don't need to write introduction and the line. No, it's an essay. Okay? It's not a literature review of the case or subject, please. But it has to be case-specific and case-focused. And please, you have to be referring to the patient you manage within the commentary. This is very important. And please avoid copy and paste plagiarism of any form. So the format is as we've known. If you go to the body, if you're talking about rupture ectopic in a patient that doesn't have shoulder tip pain, which is you expect, you need to discuss it. Okay? If a woman has abdominal mass and you are doing ultrasound, you need to say why you are doing that. If you are doing MVA instead of medical evacuation for a woman with incomplete miscarriage, you need to explain why you've chosen that. And if you are doing subumbilical skin incision for laparotomy for ruptured uterus, you need to tell us why you did that. So it's not just, you need to tell us why you did what. And if you're able to do this yourself, as I said, it transforms you and makes you the specialist we want it to be. Finally, the referencing. We prefer Vancouver, which is a type of numeric referencing. The other type is author date, example, Harvard. So you number it the way, I'm sure all of you will be familiar with it. The way you reference it, that's the way you number. And the guideline is rich in examples. So go and look at it. Note this rule of 10. 10, not more than 10 years to the date of exam. Not more than 10 references per case. These are important, okay? If you're going to meet me in an exam, you must be able to tell me about this reference. So I've tried to label these things for you. Publication year, volume, issue, and pagination. So you should be able to know what they mean and go and look at them. So finally, the book of cases is a key requirement for Part 1 national exam. It involves extensive studying and literature review. The number of cases has been reduced to 15, and we'll tell you how you distribute it. Each case report must be signed by a supervisor, and we expect the trainees and supervisors to follow the guidelines, please. Finally, if you write these cases yourself and comment on them appropriately, they're going to be transformed, into the specialist we want you to be. Thank you so much.
Absolutely. Please, a round of applause for Professor Cyril Dean. If you write your cases yourself, you will be transformed into the specialist that we want you to be. Thank you so much again, Prof. We appreciate you. The next speaker is our one and only Dr. Adetunji Adeniji, Professor of Obstetrics and Gynecology, researcher, principal, postgraduate medical trainer, and educator. Ladies and gentlemen, please bear with me. I am going to take 2 minutes to talk about this distinguished scholar who's going to tell us about the anatomy of casebook. Professor Adeniji had his medical education at the College of Medicine, University of Ibadan, Nigeria. His postgraduate medical training in obstetrics and gynecology was at the University College Hospital, Ibadan, finishing with the fellowships of both the Faculty of Obstetrics and Gynecology, West African College of Surgeons, FWACS, and the National Postgraduate Medical College of Nigeria, Fmcog. He also holds the Doctor of Medicine degree of the National Postgraduate Medical College of Nigeria. His clinical research interests are in maternal-fetal medicine and labor management. His current institutions of primary affiliation are the College of Health Sciences, the Ladoke Akintola University of Technology, LAUTECH, and the LAUTECH Teaching Hospital, Ogbomosho, Nigeria. He's also a visiting professor and consultant to the University of Sierra Leone, College of Medicine and Allied Health Sciences, and the University of Sierra Leone Teaching Hospitals Complex. Professor Adeniji is a supervisor and examiner to both the West African College of Surgeons, the National Postgraduate Medical College of Nigeria. He's also been member of faculty board of both colleges, and he's currently a council member of the West African College of Surgeons. This evening, Professor Adeniji is presenting to us the anatomy and structure of the casebook, long commentaries. Prof, we welcome you. You have 15 minutes. Please go on. Thank you.
Thank you very much, my DVC, Professor Ogo. My appreciation to the faculty ESCO. I also want to greet the co-trainers on this blog, both senior and colleagues, and I welcome all participants. Professor Ogo has talked to introduce me by telling us the topic I'll be talking about, and it's just straightforward anatomy and structure of the casebook with emphasis on the long commentary. Now, so we shall take it in 2 segments, actually, principally. The long commentary is more or less like introducing us as trainees into the rudiment of research in the early part of our training. I'm happy that Professor Booker and Professor Dim took the podium first, and they have made my job simpler. So we are going to divide this presentation into 2 parts. We will talk about the anatomy of part 1 long commentary, and then we'll talk about the structure of long commentary itself. And what will we talk about under the anatomy of part 1 long commentary? We'll address when we start, what topic to select, what research methods are acceptable, what writing style to adopt, what font size or line spacing to employ, and the total word count I should aim for all along in each of this section. And in the structure, we will discuss using this acronym, which I will further expatiate on later. Now, going into the first aspect, which is the anatomy, I'm happy also that Professor Booker Dim had mentioned about when to start the anatomy of the casebook. Let me say clearly that most of what I'll be talking about are taken from the guideline for the part 1 casebook and long commentary as published by the Faculty of ONG, National Postgraduate Medical College, the February 2024 version. So to start time is 1 year after commencing residency. And the reason are so simple, as explained by Professor Booker, by that time that you'll have been well grounded in the management of cases, you have been very versatile in the department, and then you'll be able to do justice to your long commentary. Now, what are the topics you can select? You can actually select from any of the aspects of ONG, either in obstetrics or in gynae. But the key factor here is that it must be relevant to contemporary practice of OBGYN, especially in Nigeria. Well, you are not expected to do a groundbreaking study, But whatever you are doing should complement or clarify existing knowledge on any topic you so choose to study. And for your research method, it can either be prospective, it can be retrospective, it can be quantitative, and it can also be qualitative. However, if you choose to do a qualitative study, there must be quantitative component to it. The faculty by itself does not encourage entirely qualitative study. So if you are going to do a qualitative study, you must have quantitative component to it. Now, if you choose to do a prospective, and I think this is one thing that many of our residents are not doing, you can actually choose your prospective study as a pilot study for your part 2 dissertation. What do I mean by that? You can pick a topic that you will eventually write up as the dissertation for your part 2. You will just do a pilot study of that study and publish it as your long commentary. It is acceptable to the faculty. In that way, you are using one stone to kill two birds. Okay? So I think this is an area that residents should now explore further. Now, what is the writing style? The writing style prescribed by the faculty is the British style. Don't forget our education is patterned after the British system. Now, what do we see with residents? You write and then you intersperse British and American style. It is never acceptable. I know many of our examiners are tending towards the American, but then the faculty still recommend British. But if you want to do American, make it entirely American all through your writing. Now, what are the font size and spacing acceptable? Professor Dean just mentioned size 12 Times Roman is what is prescribed, and it should be double space. So you want that. So in all entirety, when you do, your total word count for your long commentary should be between 2,500 to 3,000 words. And this excludes your abstract, your figure, table, and referencing. So your writing, the text itself, to be between 2,500 and 3,000 words altogether. Now we are on to the structure of the casebook long commentary. Now, I did say earlier with an acronym that it will be divided into 8 segments. And one of the 2 segments is presented on this slide, abstract and introduction. Your write-up must be preceded with an abstract, and the abstract must be structured. What do you mean by that? It must have the following 5 components, and that is background, introduction, objective, method employed in the study, your summary of your result, and the conclusion you drew from the study. Now, in all together, the word count for the abstract should not exceed 300 words. And 300 words is just barely about a page, or about a page and 4 or 5 lines on the second page, actually. Now, introduction. Your introduction is expected to be between 500 and 750 words. And that is the maximum of about 3 pages with your introduction. It should focus on relevant local or international literature on the research topic. What does that mean? It is not uncommon that you find a candidate in the bills to lengthen the introduction go to irrelevancies. Let me give you an example. You are talking about, for example, maybe you are talking about induction of labor, and then you are talking all along about the anatomy of the service, and you dwell extensively on that. That is not the topic of your study. Your topic is on induction of labor, and your reference as to that service should be in relation to Bishop Scoring. So giving us all the gamut of anatomy is not helping with your introduction. Now, the third component of the structure is method, the method you employ for the study. And it is expected this should not be more than 500 words, which is just 2 pages actually. It should include the site of study and the period under which the study was conducted. Now, this is missing in most of the long commentary we see. They will quite state it's done in one institution, but when the study was actually collected, the duration of the study most of the time never mentioned. Then the population studied, you need to mention that. The research method you employed, the sampling technique, the statistics, and the analytical software must be indicated. And steps you took in complying with ethical standards must also be enumerated in this. Now, when you get to the result, it is also expected that your result will not be more than 500 words. Actually, in this case, it is not about your table. It is the text that follows your table. For every table and then figures, you are expected to put a small explanatory below each of them. And these are the ones we are talking about as 500 words. So your result must be presented in tables of figure to a maximum of 5 tables or 5 figures, or a mixture of 2 to a maximum of 5. Each table figure per page, each table and figure must be written on the page with brief explanation beneath and on the same page. Do not duplicate same data in both table and figure. It is very not uncommon that we see a candidate has presented something on a table, and it will, in the bid to be colorful, will also take the data presented in that table and go and present it on a pie chart or a bar chart. That same data is not acceptable. Once you are presenting something on a table, it doesn't come in a figure. Once you are presented in a figure, it doesn't come up in the table again. Now, your discussion, which is the meat of your study, apart from the methodology, is to be between 750 and 1,250 words. That is between 400 to 500 pages in entirety. It should focus and discuss relevant findings, either positive or negative, not merely comparing findings with other publications. What do we mean by this? We find candidates who will tell us, in my study, in this study, we have found that, for example, pre-induction breacher score was this. This compares to what was found in AA. Now, the point is you are just talking. You have not told us what made it to be possible that you are finding. What were the reasons that you have similar finding? Or if you had different results, what were the reasons for this dissimilarity? Those are the measures of discussion. Discussion is quite different from comparing this finding. So you must discuss the impact of your findings on any current practice or knowledge, whether it is supportive or in conflict. The implication of your findings on current practice or knowledge, you will discuss it. And I encourage residents to be bold. Be bold to differ from long scientific theory. If the finding from your study can justify your departure. So if you find something in contradiction to what is everybody saying, please be bold to say it and give a really valid explanation. What you thought might be responsible for your own finding. It is your finding. Your examiner is not supposed to know more than you if you have done your work very well. Where necessary, recommend further research. Now, your conclusion must be on the major implication of the research finding, and then preferably, you should do this in the paragraph. Your conclusion is not supposed to be extensive. The same thing, you must derive your conclusion from your findings only. You cannot bring your idea into the conclusion. Bring it from what you found. And your recommendation, acknowledgement should be a paragraph-ish, not a lengthy one. Okay? Now, referencing, I'm happy Professor Dim just had made my work here easier in this aspect. The referencing method recommended by the faculty is Vancouver method. And this is just a numerical listing and numbering. Okay? And what you need to know is that this also should be double space. And you will name all author by stating their surname, followed by their initials without a full stop in their initial. And if you have more than 6 authors, you list the first 6 authors, followed by a author. You cannot list 3 authors and say a author. You must at least, if there are 6 authors, list all of them. But if there are more than 6, you list the first 6 and follow it by a author. Now, at least 75% of your publication must not be older than 10 years from proposed date of your examination, except if you are quoting landmark publication. It is advisable that your referencing should not be more than 15 to 25 publication, and not more than 30% of this should be from textbook. That means journal publication should not be less than 70%. Now, in this 70% journal publication, if available, 20% of the citation should be from your candidate institution. If your lecturer, your trainer have published on the same subject, you must cite them. And then if you have to cite, 50% of the citation must be from Nigerian publication, except if work had not been done extensively on that topic. So what that means is that if you have taken all these 50% and 20%, the 30% will come from international publication. Now, this is a citation listing sample. You will need to look at it, how to do journal article citation, chapter in books or textbook, or if you are taking your publication from internet. Now, I have included this aspect, useful free citation generator website. They are free, and they are my Beep citation machine, and cite this for me. If you take your publication, the title of your publication there, they will format it for you in Vancouver method so that there won't be any error for you. But the good thing is that you must learn how to do this also by yourself. There are other things like Grammarly, like Sonero, but those are paid for. You need to pay for them. But these ones are free. And that is why I've included it on this slide. So I once again want to acknowledge that I've taken all this presentation from the guideline for the pre-part 1 casebook and long commentary in the Faculty of Obstetrics and Gynecology, National Postgraduate Medical College, February 2024 edition. Thank you for listening, and questions and answers will follow. Thank you very much.
Thank you so much, Professor Adetunji Adeniji. Ladies and gentlemen, please, all the 417 participants on the platform, a virtual round of applause for Prof, please. Thank you. Please keep your questions. We'll have question time coming up shortly. Our next presenter is our beautiful, delectable Professor Nana Hawa Madugu, MD, Professor of Obstetrics and Gynecology and Fellow of the Faculty of Obstetrics and Gynecology and Emergency Medicine, National Postgraduate Medical College of Nigeria. Professor Nana Hawa Madugu holds a double master degree in Public Health and Leadership and Management in Health from the University of Washington, United States of America. Prof is the co-founder of Women Health International and is a past president of the Medical Women's Association of Nigeria, Kaduna State. She is an experienced professional with more than 2 decades as a consultant obstetrician gynecologist and researcher at the Ahmadu Bello University and the Ahmadu Bello University Teaching Hospital, Zaria, a center where she just finished as the head of department. Professor Madugu is the current treasurer of the faculty. She's an examiner with our college and board member to both faculties of obstetrics and gynecology and emergency medicine. Over the next 15 minutes, Professor Nana Hawa Madugu will share with us the common pitfalls that we can experience while putting together our casebook. Professor Madugu, please, you have the floor. Thank you.
Thank you very much, our dear Professor Rosemary. Please, I'm trying to share. Can you share from your side? Or Professor Umira, can you send from your side, please? I'm having problem sharing my, where is the secretary?
OUJ.
It's 21 hours.
Thank you very much. The chairman, the faculty chair, the faculty secretary, other board members, senior colleagues, and our candidates, you're all welcome to today's program. The previous speakers have actually discussed what are the things that are necessary for you to have a good written casebook. I'll be talking about the pitfalls, what you are not supposed to do. So we'll be looking at copy and paste, poor case selections, complex cases, incomplete commentary, poor referencing, and I'll conclude. There are so many pitfalls, but we just pick on these few ones that are very important. We all know what pitfall is about. That's hidden errors, that are not easily recognizable errors. And in casebooks, or in most of the research books or works that we do, there are also hidden mistakes, problems that can easily be overlooked. And it has a tremendous consequence on the quality of casebook writing, because most of the time you want to publish these books. So if you don't have it well written, you are going to have problems in getting it published. So the role of the supervisors is to be able to point out some of these pitfalls in most cases. But however, some of the supervisors also, we miss some of these cases. So it is therefore pertinent for us to be familiar with some of these pitfalls. Thank you. So the first, next slide, please. The first one we're going to be looking at is copy and paste. Most of us, let me not say all students, most of us copy and paste. The issue is we don't even know how to copy and paste properly. What happens is that the failure to, the narrative may not reflect the patient's unique circumstances, risk factor, or presentation. You only copy and paste, but you are not copying and pasting what is peculiar to that particular patient. And what happens is that it reduces the educational and clinical value of that case, because each patient is individual, as an individual. And even if they're presenting with the same illness, it might present in different ways. And they might have other comorbidities that are associated with it. And we are just picking that particular symptoms and pasting it wrongly. So decision based on inaccurate copying information can compromise the patient's safety when it comes to management of this patient. And especially when it comes to the critical or emergency cases, when you see patient, management of preeclampsia, fetal distress, we look at those fetal distress. Most people don't write fetal distress. You have had a candidate, your senior colleague must have written on fetal distress. The next thing you write on fetal distress, copy and paste what the patient has said, what the other senior candidate has done. Then over-reliance on templates or past notes prevents students, trainee from practicing history-taking, critical thinking, and independent documentation skills, which is very, very important as you go along in your own career building. But if you continue to copy and paste, what happens? You definitely not have the ability to do all these things. Then there is the loss of that patient voice. The important news is that means you describing that particular patient. Each patient, as I said, is individualized, and they have their own comorbidity. Some of them might have uterine fibroid, but have psychosocial issues, financial issues, family issues that you have left out. Especially when you're talking about treating patients that are, especially infertility patients or some gynecology patients, you find out that you are missing some other areas because you are particularly copying and pasting that just similar disease, not the patient on its own. You are not treating the whole patient. Next slide, please. Now, what do you do when you see cases, when you have finished writing your casebook? I just gave a small checklist. You have to find out from yourself. Did I manually confirm all the demographic details? I remember one of the exams I took, one candidate that came for an exam, and the patient delivered last year, and he's telling us that the last menstrual period, the EDD was this year. So it was obvious that copy and paste. Immediately I showed the candidate, look, see what you have done. She shouted, Mugbe. I didn't even know what was Mugbe. It was somebody very close to me was telling what is Mugbe. That means he knows that he has done something wrong. And that is the problem of what? Copy and paste. He failed that exam, but I don't know if he finally passed overall because it's not a rate determining factor. So those are the checklists you have to check. You have to check if there's any contraindication on this patient. Is every sentence related to this patient? Have I removed the old name, the date, and the diagnosis? That if you have to copy and paste. Is the writing on my own words, in my own writing? And have I checked for plagiarism if it is, and we have used this tool to check. So please make sure you do a checklist of copy and paste anytime you're writing your casebooks. Next one we're going to look at is the issue of poor case selection. Picking a case that is too common. You see a case in your short case, normal delivery. Guess what? Even nurse midwives have normal delivery. So you want something that is what? That you can tell us, you can learn from. E.g. uncomplicated delivery or routine fibro. These are not normal cases. You should tell us, that means that case is failing to highlight what makes the case different from the standard presentation of management. So no new insights, teaching points or challenges. And at this level, that's what we want from you. Missing key investigations, operative details, or follow-up. Some we just finished, patient was discharged, and they was asked to come so and so, and that was all. But details of the follow-up, what happens? When have you did, like a case of pre-eclampsia, eclampsia, after 6 weeks, the patient has to be referred to the what? To the medical clinic for continuous treatment. What documentation leading to vague lifetime or unclear diagnosis? You see cases like that. So unclear why certain interventions were chosen. You saw it from another page, you copy and paste, and you don't even know why that intervention was done. No reflection on alternative options in obstetrics and gynecology practice for that particular patient. A patient that has come with bleeding in early pregnancy. The next thing is what? Evacuation. There are cases for what? Expanded management, medical management. No, they don't use that because that other patient, the way you copied it from, that was what you did. You didn't look at other options of practicing, of treating that particular patient. And offering nothing beyond standard textbook knowledge, no complications, diagnostic dilemmas, or evidence-based data, and lacking, as I said, learning opportunities. So selecting, choosing a case with verifiable or relevant information, you'd rely heavily on patient's report, symptoms that somebody will tell you, this is my presenting complaint. You are not collaborating it with what you expect, especially when you are writing your history of presenting complaint. That is your own words now. Now you have to elaborate and make sure that the history of presenting complaint is collaborating with what? The history of presenting a complaint. So there's no lack of objective findings, laboratory or imaging. Most people don't go in for CT scan or MRI. Either maybe it's because it's expensive, but you cannot come up with the diagnosis without having a complete investigation done. No multidisciplinary approach, which we are very particular. We don't do mostly here, especially when you're writing your casebooks. No multidisciplinary disciplinary input when required. Oncology, neonatology, anesthesia, interventional radiographer. All those things should be written when you need them. Not showcasing diversity or different demographic and condition. Especially some of us that are in the north, we make sure that you take people from the north, take you from the south, that come to the clinic, so that the cases will not just be, okay, this is from the north and they are from the northerners or the Hausas, whereas you have other people from different tribes that are coming to the hospital. Why don't you see the cases and make it what different, showcasing what the diversity and how the cases are in different diversities. And missing informed consent, most patients, you go for surgery, you get informed consent, but you don't actually counsel them on what is supposed to be done. So your case is not complete. Even if you have written on it, you must show that this patient was well counseled and explained, not just counseling, explain, she was explained, she knows everything, and about the case and the benefit of the management want to give to this patient. Everything must be well explained to that patient. Ethical concerns about management not being addressed is a poor case selection. Everything must be well documented when you are doing your case. So what are you supposed to look at when you are looking for a case? Does this illustrate a clear clinical problem? Does it contain a complete information? The history, is it there? The history, is it well written? Examination, investigation, management, outcome, even follow-up has to be well documented. If not, your case is a poor case. Is the case representative of common obstetric and gynecologic conditions? Does it allow discussions of guideline and evidence base or teaching points? Sometimes you treat patients the way you want to treat, but there are guidelines that you have to follow. So those guidelines will need to be seen when you're writing your cases, that you are following social guidelines, which is very, very important. So the next one we're going to look at is complex cases, selecting extremely rare cases with no teaching value. Some rare conditions are interesting, but often no practical takeaway, especially when you're presenting that case. So, but those ones can be a case report when you want to publish it. But when it comes to this case book, it might not be that very, very suitable. Too many unrelated comorbidities that distract from the main issue. As a gynecologist or obstetrician, we want you to bring an obstetric case, not a case that has what? Obstetric, that's a pregnant. Maybe somebody with trauma that is pregnant is being managed by the surgeons, and now she's pregnant and you are writing the case. No, it must be primarily an obstetric case. Unclear, uncertain interventions were chosen, as I've discussed. No reflection on alternative. Sorry, we are going back. They're reporting investigations. So how do you avoid these pitfalls? So they choose rare but educational cases, ensure that it's a complete, clear, verified, especially when you're having the MTD, that's multidisciplinary team treatment. Make sure that each management by the other team are well documented in that case. And some cases that need multidisciplinary approach must be taken as such. If not, your case is a poor case. Maintain ethical standards, including patient anonymity and consent. Focus on case around a key learning point, even if it's with the multidisciplinary treatment approach. Compare management, I said, with current guidelines. We'll look at incomplete commentary, failure to link symptoms to physiology. And Professor Dim has already discussed most of these things. Simply listening symptoms. And as he said, it is not literature review. It is a commentary. That means you have to explain each symptoms and explain why. Example, reporting severe epigastric pain in a preeclamptic patient, and you are not explaining its relationship with the liver involvement. You must be seen writing all those things in your commentary. Providing a list of differentials, but not explaining why each condition was considered or why this alternative was taken, the other one was excluded. Stating what was done, without explaining why it was done. For example, an emergency stay was performed without discussing the indication, alternative options, risk benefits, and also not acknowledging areas where diagnosis was unclear, which is very, very important in some cases. To make a diagnosis might be very, very difficult. You make sure that you write it and explain why the diagnosis was unclear. That's inside your commentary. And guidelines where ambiguity is necessary. Failure to describe how symptoms or vital signs change over time. You had the surgery, for example, vesicovaginal fistula, and then you are monitoring the patient for the next 2 weeks. And you said the surgery was done and she was discharged after 10 days. No, you have to tell us every day what happens until the patient becomes dry before discharge. So you have to see it day 1, day 2, day 3. That's how you're supposed to write. And each day you write in your commentary, this is what is expected and this is what the patient has. Not indicating whether the patient responds to treatment is also very important. It's a very incomplete commentary. Inadequate follow-up, especially when you're talking about postpartum or post-operative follow-up. Long-term complications, especially with those with pelvic inflammatory disease, the reproductive impact that it has, the occurrence of risk of that impact of the infection, and also those who are actually having that problem of infertility later in life. Failure to discuss complications encountered during any particular surgery. Nobody is forcing you not to talk about complications. Complications can occur anytime. So please take your time to talk about the complications and how you're able to solve those problems. What could have been done differently? What did you learn? Learning points for clinical and practice. This is what I have learned from this. From this other commentary, this is what was done. But in my own case, this is what I did and I learned, and this is what I learned from it. Not commenting on patient counseling, as I said. Patient counseling is very important. We normally take this for granted. Patient counseling must be in your commentary, and it must be in your cases when you're writing them. Informed consent must be written. Emotional and social factors also must be written. And in cases where you have dilemma or for example, mode of delivery of HIV patient, you must write it in your commentary so that your commentary will be very well written. Poor referencing, we have talked about this in poor referencing, because if you take a reference that is older than 10 years, what it means that you are misrepresenting the correct practice. You know, in medicine practice, it changes every time. There are so many changes. So if you make it more than 10 years, as Professor Adetunji has said, that means you might not be doing the right thing, and things must have changed within that time. Sometimes you see poor author names, a journal, your publication, everything is not well written. Missing a volume inside the volume, especially when you're doing the referencing, the issue, page numbers, all these have to be taken into consideration when you are writing your references. Using secondary, there's one important one. Using secondary and summary instead of the primary source. You see, you write a case, and from that case, you see that you look at the reference on that for that particular case, and you just copy the references on there and put it on your own instead of writing it from the beginning, from the primary one. So that one is very, very important. There's a poor referencing. That means you didn't actually look at the copy, only copying the reference from another person. This weakens the clinical reference relevance of that of the review, and makes it difficult for the examiners to be able to look at your work very well. And also use updated peer review journals. We're talking about how to avoid this pitfall. Make sure that you use peer review journals in obstetrics and gynae. Follow one consistent reference system. We have said, Prof. also said that Vancouver is what we need. Read original primary articles whenever it is possible. Use a reference manager if you can get. I think the college, the Tero on the Mandela I think is something that those are the areas, the reference managers that we are used to, and that's what I think is available, is permitted in the college. Integrate and critique sources. Don't just list them. Make sure you list everything. And there was conclusion that common pitfalls in casebook writing, proposal, and dissertation are real. They are real. They undermine the clinical relevance of the write-up, and if not detected and corrected, they weaken the coherence, the flow, and the quality of the academic writing. Thank you very much.
Yes, all right, thank you. Please, a virtual round of applause for Professor Nana Madugu. Thank you so much, Prof. You've heard it, you've seen the pitfalls, and you've seen how to avoid it. We still have question time, so if you want to know more, just hold on. Don't go anywhere. I think we're coming to the most important aspect for those who are going to do exams, the casebook assessment. How are these casebooks assessed? How do you get your scores? And I think you need to know that so you know exactly how to write. You know, when you know where you're going to, then you know how to get there. And so for this part, ladies and gentlemen, please make welcome the one and only Professor Dr. O.U.J. Umara, Professor of Obstetrics and Gynecology. He had his residency training at the University of Benin. He is a fellow of both the West African College of Surgeons and the National Postgraduate Medical College of Nigeria. Professor Umara is the current chairman of the Sogon Eastern Sector and is the faculty secretary at the National Postgraduate Medical College of Nigeria. Prof, you have up to the next 10 minutes, please, to give us the casebook assessment. What should the candidates know? What should their trainers know? Over to you, please, Professor Umara.
Okay, thank you, former N11. Thank you for your services this evening and for your anchoring this program. Thank you so much. Let me also thank all the presenters so far because they've really done all the job. I have nothing more to add, but just say one or two things. When we talk about casebook assessment, we're actually looking for three things, only three things. One, is the casebook authentic? Are the cases authentic? That means these cases you are selecting, are they real patients or AI-generated patients or phantom patients? That's one. Then two, did these candidates actually participate in the management of this case? That's two. And then three, does the candidate understand what he or the condition he has managed? Those are the three things you are assessing. And as many examiners or assessors are already very experienced and they can tease out these three qualities from each case presented. I was so happy when Professor Jim made a statement, which I want everybody to go home with. He said, if you write these cases yourself, you will be transformed into the specialist we want you to be. And that is the essence of this casebook. And that brings me to the issue of copy and paste. The issue, copy and paste for the National College is a no, no, no. And assessors and examiners are encouraged that once you pick a case, even if the person has written 10 pages and just one line tells you that this thing is copy and paste, that case must be rejected. There are no place for copy and paste whatsoever. If I review, unfortunately, most examiners are, will I say, mild, but that does not help the case because the candidate comes to exam and cannot defend what he has written. If I review casebooks, oftentimes I have like 5, 6, 7, 8 cases for the candidate to replace. And when we are replacing the cases, it comes with an added burden that each of those cases must be certified by the current HOD that those cases are authentic. They must be signed out individually by the HOD so that you don't go and recopy and paste. There are so many things. I've seen cases managed in Nairobi Newe and was referred to Fmcog. It's funny. Then that one was even so, will I say, hopeless also, that in the first page is his name, in the second page under acknowledgement is another person's name. So please, I'm using this opportunity to remind assessors that copy and paste is a no, no, no. Once it's detected, that case must be rejected because it really negates the essence of the casebook, which is for you to understand. Once you've managed a case in a standard way, we become master of it and then translate that to our patients. So that's the trust of our assessment. So let me give you this what the examiners are given when they assign the casebook to assess. There is this general case checklist where the cases adequately selected from the recommended modules I'm happy Professor Cyril is also giving us a new pro forma that I think we are going to adopt to make it easier for everybody. We are the adequate number of short cases, 7 obstetrics, 7 gynae. We are the cases relevant to contemporary OB/GYN practice, especially in Nigeria. We are all cases in reported speech. When you're writing a casebook, you're only reporting of what happened. So all your tenses must be past, not present, not future, but past, because this is what you did. This is what you did. This is how they were drawn. We had introductory sections concerning contemporary and evidence-based practice. Was the language consistent all through the text? Well, we encourage British English, but if you decide to go American, no problem, but it must be consistent all through. If you are using British spelling, it must be British all through. American must be American all through. Just like we discourage mixed feeding in HIV, we discourage mixed oscillating between British and American whenever you want. So, and this is easy. Set your laptop to the English you want, and it will highlight the ones that are not consistent with that. We had that grammatical and syntax errors. This is very common. Oftentimes, I recommend English language editors for some of the candidates. Please, there should not be so many. Typographical errors. Please take care of your typos. Some of you, when you catch them copy and paste, they tell you it was typographical error. There are no typographical errors. Those are just copy and paste. So in order not to blame typographical error, please go through your cases or your text at any moment to make sure they are not typos. Was the name considered all through the, okay, I've said this, was each of the case signed off individually by a supervising consultant? Yes. We now want each case to be signed off by supervising consultant. The reason for this now is that we'll be taking note. If we see a case of copy and paste, we are going to match it with the consultant that signed it off. If this consultant is of the National College, we are going to call him. And ask, why did you really go through this case? And at least by the time we call you 2 or 3 times for cases like that, then the college might have no reason but to blacklist you that you're not really helping us in training the residents, and we note you for that. So consultants, it's not a question of signing. The presidents are smart. They will catch you when you are in a hurry and say, oh, sir, you were there when I wrote this case and you just sign. No. I know a candidate in my center that brought a full casebook for me to sign. I think I was HOD then. And there was like a blackmail. Oh, we just have 3 or 4 days to submit. I said, you have your casebook, you've been writing it for 2 years. You now want me to sign it within 3 days. It's not possible, though. I said there are 2 options. Either you remove my name and submit, or if I must sign, I must go through. Eventually, he allowed me to go through, and goodness, it was disaster. I read through page by page, made a lot of corrections. Ladies and gentlemen, this is about 7, 8, 9 years ago. Those corrections are yet to be made today. What happened? The guy just abandoned the National College. That's okay. We don't encourage copy and paste for any reason. It's either you have the quality or you don't. So supervising consultants, please take note of this. Did the head of department attest to the authenticity of the cases and the management? Yes, this is the response of the HOD. If we see the HOD signature, we should believe that all the cases are authentic. If they are not, that means HOD, that something is not aligning well. So we all the abbreviations in the manuscript captured any evidence of plagiarism. So these are the general checklist that's all for each case. This for each case, the assessor is going to check them out. Okay. Then for individual cases, if it goes to obstetrics, is the case relevant? Is the biodata complete? Clinical history complete? Physical examination? Relevant lab and radiologic investigations? Are the dates consistent throughout the report? Like somebody said, some of you run the antenatal clinics or postnatal clinic on a Saturday. Some do elective myomectomy on a Sunday. How is that possible?
Okay, were there management deficiencies noted? For the discussion, focus on the case managed. Like the other presenter said, not literature review, but the discussion must be focused on that woman that you managed. Everything must be related to her. What major aspects were left out in the discussion segments? We are references cited in text and consider with Vancouver. Yes, this is another way. Let me tell you straight away. This is another way to catch, copy, and paste. Whichever search engine you are using, if you type in myomectomy, it will start giving you articles from 2005 down. So you can't be writing a commentary in 2005 and your latest reference is 2000 or 2001. That means you did not. That means you must have copied, lifted that secondary reference from somewhere. And when I point out this to some people, what they do, they now go and just change the date. You search for the article, you won't see. Those are not good at all. So was the LCG and pathograph included? Like we said, like Professor Cyril said, each labor case must have a pathograph. Now we are transiting to LCG, and with this transition I've been on for the last 2 years, I think maybe probably from next year, it just has to be LCG. You have to align with the WHO, align with SOGON, align with the Federal Ministry of Health. Those are the recommendations of those authorities. So any evidence of copy and paste, then decision. So this is, and then correction requested. This for each obstetric case, and almost the same thing for each. You can see they have this case for each case, and then before you now get to gynae. So gynae is almost the same thing. So nothing different. It's the same thing we are looking for. So this, you now know how these case books are assessed. You now know what we are looking for. So the onus is on you. My advice is always do the hard labor now. Write authentic cases that you managed. If you do that, I'm telling you, you don't need to go through that case book when you come for exams. Remember, in each segment of the exam, in the exam, you must pass at least 2 segments. The oral goes with casebook. Casebook is 20 marks. Viva is 40 marks. Why should you not get 15, 16, 18 in your casebook and make sure you pass that segment? Instead of failing that segment and maybe in the written you also fail, and that fails you. Meanwhile, you pass clinical. When I see candidates going through their case books that exam morning, it just tells me this guy did not write that case. It's as simple as that. So I think with that, the summary of it all is that 3 things we are looking for. Are the cases authentic? Did you participate? And were the cases managed in a standard way? If you do that, let me repeat what Cyril said, you'll be transformed to the specialist we want you to be. Thank you, Mr. Chairman.
Okay, thank you so much. Ladies and gentlemen, please a round of applause for the faculty secretary, Professor Oyuje Umara, who has just told us about the assessment of the casebook. And we have come to the end of the presentations. Do we have any questions? Please, with a show of hand, let's see if you have a question so that we can take it. We're meant to end this presentation, this webinar at 21:40. We still got 7 minutes. Thank you, thank you, thank you, thank you. Yes, Dr. Thomas Ikubese Wilson, your hand is up. Kindly unmute and speak.
Okay, thank you so much, Prof. Thank you for appreciate all the presenters. My question is, we were told that the short cases will be within the first 3 months, while the long cases will be after the first 1 year. So my question is, what are the cases that will come within the short case and the ones that will come within the long case? Thank you.
I don't know how to respond to that because I think that's what the first two presenters actually honed down on this. So I don't know. Go back to probably there'll be recordings of this. You go back and see how to choose the cases that we have dealt comprehensively with. Thank you.
They just follow the protocol, the guidelines, the modules presented. That's what they should choose their cases from.
Yeah, so but just a moment, if I can help him. Those timelines are the time that are encouraging you to start. Short cases are just the cases and commentaries, while long commentary means the research work. Okay? So you encourage, if you are taking to residency, 3 months after admission, that you encourage to start your case and short commentaries. Then 1 year after starting your residency, you're encouraged to start your long commentary. That's the research aspect. That's what he said. I hope that helps.
Mr. Moderator.
Thank you, Dr. D.
Yes, the moderator, please, can I respond to that? Because I think the questions he wants to be clarified is what cases should one write within the first 3 months? I think that is his question, if I understand his question clearly. You know, we encourage that the short cases should be written as soon as it's practicable. But we recommend to start within 3 months. So if you are going to start, you start with the simpler cases. For instance, if you want to start the first month, you can start with the manual vacuum aspiration, or spontaneous vaginal delivery, malaria and pregnancy. Then as you go further into the program, you now start writing more complex cases. If I understand your question clearly.
Thank you. I think that answers it. And then we'll share the recording at the end of the day so he can check as well. Professor Michael Chukwuikem Aziken, you have the floor, sir.
Good evening, ma'am. Sorry, I'm not professor. I'm Dr. Michael Aziken. I'm junior, ma.
Okay, nice to meet you.
Thank you very much. No, I am Michael, sir. Thank you, sir.
Okay.
Yes, sir. My question is about the case selection. From the modules from the obstetric block, the module 4 is basically procedures. So that means that, I was going to ask, if we write a case where we are talking about an emergency cesarean section now, it's going to overlap with a case in either module 1 or based off on abruptio or obstructed labor in module 2. So in our discussion, are we going to write about the emergency cesarean section as the procedure also, or is now going to be based off on the indication for the procedure? Same with the gynae too. If we're writing about a case where we had to do a hysterectomy and we're trying to put it as module 6, are we going to write about is our commentary going to be focused on the hysterectomy as the procedure or the indication for the hysterectomy?
What do you think?
But my initial worry was in a bit to write about both the indication and the procedure will most likely exceed the word count.
Okay, so to guide you, choose your topics and know which one fits into where. Then when you are now making your commentary, when you're now writing your commentary, we want to know what you did. What was different? What did you learn? What do you want us to learn? And so if you are talking about the case, talk about the case. If you're talking about the procedure, talk about the procedure. So you can use the same case, for instance, and in one aspect, you're talking about the procedure, whereas in another aspect, you're talking about something else, not the procedure. I don't know if I'm making any sense.
Okay, ma'am. So in that instance, you mean that whichever one, whether it's the indication or the procedure, whatever makes the case relevant.
Yes, that is the module where to fall into.
Thank you very much, ma'am.
Welcome. Patience.
Sorry, Madam Moderator, let me just quickly advise them. Just to clear that part, for short cases, you don't need more than 2 or 3 pages for your discussion. Yeah, like you said, you focus on the important aspect or the exact topic, which is 2 previous years. What you're talking about is more about 2 previous years, not cesarean section. The dangers, the importance, the significance of 2 previous years. That's what you should focus on. And we try to encourage that you shouldn't use more than 2 or 3 pages to make your discussions and your references. Like the previous speakers have said, you limit it to more local studies done in the last 10 years. So try and focus more on the importance of the discussion is for you to discuss the case, how you manage the case, and what you encountered, and according to the guidelines available. So try and focus on that and not write a summary, not too long, or rather too many pages. It doesn't make sense. But you're writing 3, 4, 5, 6 pages, you are definitely writing out of context. Thank you.
Thank you, Chairman. Patience Nduku, you have the floor.
Good evening, ma'am. Good evening, the professors, my trainers. Mine is to know, like it was said, that when you manage a case and you're writing on the case, that you should mention each day, like after you finish writing on the biodatas and the rest, and you're managing a case down to management, follow-up, that when you visit a patient, like you go for your first ward round, you write day 1, day 2, day 3, like until the patient is discharged. Like in a case where you go for maybe day 1, you have something to write, the changes, maybe day 2, day 3, you change the drug. On those days that you did not do anything for the patient, but you went to see the patient on ward round, will you still write maybe patient saying nothing was done, or must you say something every day until maybe day 5 you discharge the patient and you follow up? Or those days that you did something important are the those you're going to mention? It's just a clarification.
Doctor, there's no day you see a patient, you say you didn't do anything. That's not even a good mindset to have, that, oh, I went to the patient bedside, there was nothing wrong with the patient, so I didn't do anything. There's nothing like that. Every time you go and see a patient, you do something for the patient. You talk with the patient, you counsel the patient, you reassure the patient, you tell the patient what happened during the surgery and so on. And so when you are writing your case, you saw your patient every day. You write it that you saw your patient every day. On day 1, we removed catheter. On day 2, we changed to oral drugs. On day 3, we reassured patient. On day 4, patient had stabilized and was preparing to be discharged. Do you understand? They are simple and straightforward, okay? Every day you see a patient, it is important. All right? Thank you. Does anybody want to add something to that?
Thank you very much. When you are writing a case and your case about surgery, of course, you have to talk about the post-op management and what you see on a daily basis. And I give example of vesicovaginal fistula. You know, every day is important. The input and the output, you have to measure it. Everything has to be, and that is the management of that patient. Of course, if there's nothing there, just a patient condition is satisfactory or something, but you must show that you are managing this patient every day based on the case. It depends on the case you are writing on. You can't just say a patient they had surgery. You wrote so many write-ups, but the real surgery itself, very little, just one line. A patient had surgery, she was discharged after 10 days. It's not acceptable. Thank you.
Yeah, the thing that you summarize, you don't need to write day 1, day 2, day 3, day 4, day 5. Just summarize the salient things that happened that impacted on that management in those post-operative days. You don't need to start saying 1, 2, 3, 4. And that's why the seniors in your center will help you. The senior registrars that concerned will help you to summarize this. Remember, you don't need to have so many pages. Just be very concise and precise. Thank you.
Thank you, Prof. Olisel Zakbo. Unmute and speak.
All right, thank you very much. Thank you very much for the opportunity to speak. I'll just ask for those who will be preparing for the exams. I'm senior registrar. Those who have failed the exam 2 times, should they still submit casebook? And those who wrote 15-15, are they still bother to change it, or they should just leave it as it was before? Thank you.
If you've taken the exam before, if you've submitted your casebook before, you don't need to resubmit. That casebook is still with us, and that's the one you'll still be examined on, okay? Because it's been accepted by the college, so you still be accepted, examined on it. Unfortunately for you, the you might have been, because you have 15 cases. Assume you were examined on cases 1 and 13 the first time and you did so well. When you come again, it may not be that 1 and 13, it will definitely be another. So that means you must keep going through these your cases. You must keep remembering the cases you managed, because you can be taking on other cases. So don't be surprised you passed the case with the first and second time you messed up and you fail it. Okay, but you are not going to submit another casebook.
Thank you, Faculty Secretary. Idima Ekeoma, please speak.
Okay, thank you, Prof. Yes, I want to ask, I have 2 questions. Number 1, I want to ask concerning the long commentary. I say that if someone is writing a retrospective diagnosis for like 5 years and started the residence like 3 years ago, would that be acceptable, or what can the candidate do? Secondly, about
Sorry, take that question again. I didn't get it. Take it again.
Okay, I'm asking, like, writing on a retrospective diagnosis of 5 years study, and the candidate started residency 3 years ago. So would that be acceptable, sir?
Okay, that question was on a chat box and I answered. Yes, you can. As I am now, I've not been in the hospital for 30, 40 years. But I can do a retrospective study that spans as far back as that. So it doesn't mean it's only when you are interested in the outcome of cesarean section. You can say, let me look at the last 10 years. Those that you are looking at data in the last 10 years, you don't need to have been there when the data was collected. So it's quite acceptable, okay?
And that's why it's called a retrospective study.
Yes.
We are looking backwards into the past to see the implication on the present.
Thank you so much. All right, we have some very senior colleagues in the house. I'm sorry, my screen is not very wide, so I can't see everyone, but I know I saw Professor Adeyinka Omigbodo. Is he still here? And all the other senior colleagues who are here, we see you, we recognize you, and we thank you. We're supposed to have finished 7 minutes ago. We still have 4 hands up. We will take the 4 hands if you don't mind, but kindly make your questions brief, please. Thank you. Obina Anthony, kindly unmute and speak. One go.
Okay, thank you so much, Prof. Please, my question is on supervisors signing the logbook. If we have like 15 cases, 7 ups and then 8 gynae and long commentary, how many, the supervisor, how many will each supervisor sign? Perhaps I'm trying to get clarification. Is it one supervisor that will sign all of them? Or perhaps you have like, you meet like different consultants, maybe 3 can sign up to 3 after going through it. Just clarification on the signing. Thank you.
If the important thing is the person is their supervising consultant, the person that, assuming is the consultant that owns the case and he was sure you manage the case, that supervises the management of the case or anything, that's the one that will sign. Not that you write 8 cases and divide them 2, 2, 2, 4. No. The consultant signing for you must be sure that you manage the case. So if one consultant actually went through your casebook with you all through from A to Z, there's nothing wrong with it. But it's always good to have different ideas from different people. That's the way you learn, not just don't narrow yourself to one consultant, but get perspectives. Remember, the elephant is so big, and people, depending the description of or whoever, depends on which side the person is looking at the elephant from. So, but you at the center should be able to gather the experiences of your older colleagues from different angles, and that's what makes you the specialist you are going to be. Okay.
Let me just quickly add to that. We don't encourage one person signing all your case books. You work in a department, and in the department, you definitely have more than one consultant. You're supposed to manage patients as you rotate through the units under different consultants. That's what we encourage, and that's what we like to see. We don't like to see one signature all through. That raises a lot of eyebrows. Thank you.
Biku Sada, you have the floor. Unmute and speak.
Thank you, ma'am. Good evening, sirs and mas. My question is, for those writing exams early 2026 or late 2026 for the labor cases, are we attaching pathograph or labor care guide or both? Thank you.
The chairman is here.
Well, ideally, in all sincerity, if you use the pathograph to manage your patient, that's what you should discuss about. But in all sincerity, we are hoping that by now, all centers should be on labor care guide. You can't write on what you did not use. You can't write on the tool you did not use, and you can never attach a tool that was never used for the patient in labor. Other than that, if you see the photograph in your center and that's what you wrote on, please write on your photograph and attach it. If it's labor care guide, write on labor care guide. Try and be honest. That's the most important thing. Thank you.
Isaac Elebe, unmute and speak.
Okay. Good evening, my trainers and teachers. Thank you so much for the presentation. One of the slides stated that at least 7 cases that we write on should be part of what we discussed in our electronic profile, in the candidate's electronic profile. So I wanted to ask, is it like the cases that we write, are there like important that it must be among the cases that we signed in our logbook? That's the first question. And then the second question is regarding the type of study. The presenter said that we should dwell more on quantitative study rather than qualitative study. And if we must do a qualitative study, it must include a quantitative part. So I wanted to understand the quantitative part. Is it like comparing like a kind of categorical data in relation to a quantitative data? Like I didn't get that aspect for the long case.
Can I take that quickly so
Yes,
that we can get it clear? Most time what we see with people doing qualitative study is just descriptive study. And most time what they do is just tell us the mean, median, mode. And that is not showing that you actually understood a lot of some basic statistics. If you are able to do mean, you should be able to test association. So because this is a study and the college is not precluding you using the resources data like records, case records, and the register. It will be important that when you summarize all this and then you are getting your mean, median, you can also look at quantitative aspect of that. That means you try and associate your data, not just describing by saying 50% of the patient had this, whereas 40%, and you haven't done anything. You are just talking. And then the college does not look at, does not encourage things like a prevalence study. Okay? Knowledge, attitude, and all those things. No, those are things we are saying we don't want. But when you do qualitative, introduce some quantitative aspect to your study. I did answer that in the chat box. Maybe you didn't read that. That's why I'm emphasizing it. Thank you.
All right, thank you, Prof.
I think he had the first question. What was his first question again?
Okay.
That was the second question
The
answered
first-
by Professor Deji.
What
was the first question?
The first question was that we should write at least seven of the cases that we'll write must be part of the cases included in our discussion in the electronic profile. So I was asking, that electronic profile, is it like our logbook? Those cases, are there the cases that must be in our logbook?
Yes, ideally. The e-portfolio will soon be ready. I mean, we are descended last week, myself and the secretary and the third member. We were hoping that the current president, whose tenure will expire at the end of this month, will have completed it. So there's no, I mean, if you manage a case, you're going to have to your casebook. Of course, it should be one of those that should be your portfolio that you manage and you uploaded. It makes it easier and makes it because it would have been signed on time, real time by the supervising trainer. So they should be. I hope that clears your question.
Yes, it does. Thank you, sir. Idima Ekelman, you have the floor, and this should be the last question. We need to wrap up, please.
Thank you, ma. I have two questions. Number one, I want to ask if a supervisor that can be a consultant from the other college, from West African College. Then number two, I want to ask, still concerning the long commentary and data collection, if maybe the total number of my data is about 1,000. So I want to ask, can I use a group data? Can I bring it down to group data, or will it be an independent data? And that's a challenge I have somewhere.
I don't quite understand that question. What do you mean by total number of your data is 1,000? Can you be more specific?
Okay, total number of my participants in my study, if it is 1,000, and I'm actually using like in a case of a range age distribution, I'm using like age 20 to 30 years, 30 to 40, 40 to 50. So I'm actually asking if I should put those if I should present it as an individual data or as a group data, like that, sir.
I don't see how it will be possible for you to present individual data with 1,000 participants. And the college does not hamstring you how you choose to present your data. You can actually, for ease of presentation, group. And actually, most times when we present data, you group if it is something that is quantitative. For example, if you are doing continuous variable, you can actually group. If you are talking of age, for example, and you have 1,000 participants in your study, to make it more tidier, you can group the age range of your participants, and there will have been references for your grouping. They are usually what you want to do. If you are taking, for example, you've taken your participant from age of 15 to 35. You can decide to say 15 to 20, depending on, so long you can have scientific-based justification for your age grouping. The same thing with parity. So long you have scientific justification for your parity grouping. So grouping data is universally acceptable, and the college is not hamstringing any candidate on how you present your. But if you have issues with your how you group, then the examiner is going to pick you up, and that is where your supervisor and your senior will guide you better in how to summarize your data for presentation and analysis. If you are using individual data of 1,000, you cannot actually analyze that effectively if you don't group. Thank you.
Thank you, sir.
All right. To answer the first question, yes, For the case books, whether it is a trainer from the National Postgraduate College or Western College of Surgeons, a trainer is a trainer. Whichever unit you are, and whichever case you want to you manage and want to write up, the case is registered under a particular consultant. As long as the consultant and is a trainer in that institution, he can sign your casebook for you for the part 1 log short cases. It is only when you come to part 2 that the college insists that your first supervisor must be a fellow of the National Postgraduate College, and a fellow of the Postgraduate College can be a second supervisor. So I want you all to get that very clear. Thank you.
Thank you very much. Ladies and gentlemen, it's been a beautiful outing.
Sorry, Chairman. Sorry, Moderator. I heard there are some questions on YouTube. Remember, we had over 250 people on YouTube. There are some questions there. And so I don't know. I don't know if they are.
Even there's some questions. There's some questions there. I think what we'll do is.
Yeah, most of the questions here, I answered them. Most of the questions on the chat box. Just that most people, they ask questions on chat box, they won't go back to look for the answer. Most of them still raise their hands here. So
how do you answer the ones
I just
on
can't
YouTube?
get it. That's the problem now. Dr. Iwara, are you? I don't know. Let me see. Okay, it's posting it now. The media support is posting it. Good afternoon, sir. My road boats was an NPC in 2023. I passed WAS but failed national. I want to make inquiry concerning getting exemption. Or do I need to rewrite the examination?
For primary.
You rewrite the examination. Is it primary? The person did not say.
Yeah.
Yeah, if you are past West Africa primary, just apply for exemption. Apply for exemption and stay within 5 years, and you'll get it.
But then you must know also that there is no exemption at membership or part 1 level.
Yes, there is none. But if it's primary, I think it's primary for the person to talk about exemption. For part 1, you have to do the exam. And confused about 1 extra case report. No, we are saying you must write 7 cases of 7 cases gynae, then 1 extra in either. And wherever you choose your short commentary, the extra short commentary, the long commentary will not have to be on the other one. So you have either 8 obs, 7 gynae, and 1 long commentary gynae, or 8 gynae, 7 obs, and 1 long commentary obs. Sir, please say patient lost the follow-up. I answered this. If he's lost the follow-up, that means you don't have all the details in the case, so you can't write it up. Thank you, sir. Please, what is the minimum number of years for a retrospective study and that of a prospective study? It depends on the study. But oftentimes, don't tell us you want to review a case for 1 year or 2 years, or at 5 years, 10 years, it's okay. I've answered this other question. I think that's all. Our chairman, I think Professor Oji's hand is up. If you can take him last, then we can end.
All right, Professor Ernest Oji, you have the floor.
If the secretary, the person asked a question that he wrote West African National, he passed one and failed the other one. Can he get exemption from the one having failed the exam? So I want you to note what he said. He has already failed that exam, but he passed the other part of it. Can he still get exemption having failed that exam before? That college. I want us to clarify it.
For primaries.
I didn't say whether primary or whatever, but he has failed the exam.
For primary, can get exemption. For membership.
Okay. I just want to clarify it because he has failed the exam. I thought the exemption is only if you have not attempted that exam before.
No, that's the Old Testament.
Okay. That's okay. We are in New Testament. Okay,
there is actually a hash to that question, which most people don't know. If you have failed a stage of the exam of national, or you have gotten an exemption at any stage of the exam, you may not get a faculty prize. Eventually, even if you pass well in other section later. So people should know that all stages of the exam are also judged when you are going to get a faculty prize.
All right, thank you very much, ladies and gentlemen. Faculty Secretary, please, can we have the vote of thanks? Thank you so much.
Okay, let me start by thanking the anchor and the chairman for this session, our wonderful and ebullient, elegant DVC, Academics University of Port Harcourt, and the immediate past N11 for the nation, Professor Rosemary Ogu. It's been nice, you've anchored very well, and we thank you for all you do for the college and for humanity. Let me also thank for the person that makes this webinar possible, of course, our indefatigable chairman, who is also the CMAC of Flute. How he combines these things, what I don't know, but thank you, Mr. Chairman, for being here with us. We have a lot of senior colleagues who are here, who we must pay homage to. Professor Mibodu, our teacher, has been here from beginning to the end. Professor Saturday Took also have been here from beginning to the end. And there are so many other faculty board members who are here. The third member of Senate was on the presenter, Professor Booker, Professor Nana Madugu, our treasurer, was there. Assistant Secretary Swende was also here. All the other faculty members who are here. We also have some CMDs who, in spite of their heavy work schedule, we are here with us. We have Professor Owonikoko and Professor Rosemary Agu. Thank you for joining us despite your distance. And then the immediate part, the LOC chair of the Sogon Oluyole 2025, wonderful Sogon package for all of us. Professor Bukola has also been here with us, as well as so many other professors. We have Professor Kikelomo Adeshina, Professor Adeniyi, Professor Isa, Professor Bako. This is another DVC, University of Maiduguri. Droom is here, Dr. Mweri, Dr. Wonoga, Professor G, Commander Adaji, Dr. Egede, Professor Okohwe, Dr. Nabo, Professor Ijoma Ezome, HOD UNTH, Dr. Minad Rose Lauren, Professor Simaju, Dr. Roy Madoka, Mesaratu Bakri, all the way from Yola, Professor Mojid Momo, Professor Jiyi, Jarotimi, Professor Nzaku, who is another CMD at JOS. Dr. Sefia Farouk Usman, you are welcome. Dr. Ugwai, Dr. Segi, Dr. Filani, Amadi, Dr. John, my friend, Professor Zachary, and so many others I really can't mention. We are so many. And of course, Professor Deniji and Professor Cyril Dean, our resource persons, as well as Dana Madugu. Please, we are so grateful to you. The faculty will be mounting more TOTs and more seminars till we get all these things into our system. We might still repeat this seminar. We also the next, but I think the next will be mainly on dissertation and thesis, as well as other aspects of our training. So once more, thank you guys. We are sorry we ate into your weekend, but it's for the benefit of humanity and benefit of our women. So with this, I sign off and I call the chairman to say his final words, and then we end. Thank you.
All right. Thank you, Mr. Chairman. Once again, let me thank everybody, all our presenters, our moderator, our darling immediate past M1 president.
Sorry, Mr. Chairman. Sorry. Before that, let me thank our media support, led by Dr. Kimomo Ewara, all the way from Calabar. It's been wonderful. That's why we're able to stream this. We have 500 capacity on Zoom, and we had to stream live because total registrants we are 850. So we had to contact her, and then that's why we had over almost 300 also watching live on YouTube. So Dr. Ewara, thank you so much. We are grateful. Over to you, Mr. Chairman.
All right. Thank you very much, Mr. Secretary. Let me thank everybody, all our presenters, Professors Buka, Adeniji, Dave, Adugu, and the indefatigable secretary himself. Let me thank the moderator, Madam DVC, for the great work you've done. Our senior colleagues, led by Professor Mibodo, we appreciate your presence. Thank you very much, sir. I don't take anybody's time. We'll be having more of this. And for you, dear residents, let me also thank you, residents, for showing up. We could have organized it and you don't show up. We're trying as much as possible as a faculty to make you understand how the faculty works make the exam more friendly, make the course more friendly, enjoyable. It's a postgraduate training and it can be enjoyable and smooth. If you have any more questions or clarifications, please reach out to your trainers or senior colleagues there. They can easily reach out to the secretary or the chairman or any faculty board member for further clarification. Thank you very much, and I wish us all a wonderful and blessed week. Good night and God bless.
Thank you. Bye, everyone. Thank you so much.
Thank you.
Bye, everybody.
Bye.